All right, this is video number 6. In number 5, I left off explaining what bigeminy and trigeminy were. Bigeminy, every other beat. So 1, 2, 1, 2, 1, 2. Trigeminy, every third beat. Now you have a little beat here that you can't see. So we will start here. So we've got 1, 2, 3. 1, 2, 3. And there is a P wave there. It's inside the QRS. Don't get jammed up on knowing this again, like I said, but it is of interest. And people can live with these rhythms very successfully with little to no symptomology for a long time. Usually if you cut caffeine out of their diet, it stops PVCs, or if they're there because of stress or something, they'll also stop. All of us have PVCs all the time. The question is whether they become symptomatic or not. Now, these two rhythms, they need to be addressed. VTach, VFib, we're going to shock these rhythms. We might try with VTach to try some medications first, but we almost always shock these rhythms, and it depends on the symptomology of the patient. Here is what I've just said, kind of in writing for you to review. PVCs are caused by caffeine or alcohol use, hypokalemia. So what we want to treat with PVCs is the reason that you have them. VTach is myocardial irritability. It's usually someone's dying. Respiratory acidosis. Treatment for VTach, again, we might try meds, but if it's pulseless or not breathing, we have to do CPR. We'll give amiodarone or MEG. And VFib, that means the heart, when it's tachycardic, it's got some strength to it. When it's fibrillating, it's losing its strength. And so each minute that goes by, there's more chance of cardiac death. Heart blocks. For those of you who've been in SIM, you already know this. There are several kinds of heart blocks. First degree has a PR, so that is P from here to the start of the R is greater than 0.2. Second degree heart block, PR increases and then drops. Second degree type 2, there's a P wave but no QRS. And third degree or complete heart block, you'll have a P. So P, 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 P. But the QRS complexes are all over the place. Sometimes you have them, sometimes you don't. Don't spend a lot of time learning heart blocks. Remember that in general, the P waves do not match up with the QRS. And the other thing is, if the patient is symptomatic, they're going to get a pacemaker and we're going to fix it. So that's about all you need to know about heart blocks. Last thing on our list is pacemakers. Again, we just talked about heart blocks. There are two kinds. There's a temporary pacemaker that can be done internally or externally. In other words, we can do a couple of little incisions and put in a temporary pacemaker. We can also pace the heart exteriorly. So in other words, we put on patches similar to a cardiac monitor, except they give an electrical charge. This is not a comfortable thing. So we don't really want to do that. Then, obviously, the final one is an internal pacemaker. And here's a little picture. You'll see it right under the skin of a patient. And it's an electrical device. And it has these probes that basically put electricity where the SA node and the AV node would be in the heart. Some pacemakers, they can do all kinds of things. They stimulate all 4 chambers. Some of them have defibrillators in them, so if the heart stops, it can defibrillate the patient. So when someone has a pacemaker put in, again, it's a surgical procedure. What do we do in pre-op? What do we do in post-op? Post-op, we want to watch the incision, signs and symptoms of infection. We're going to be, of course, they're going to be on a cardiac monitor. Amazingly, pacemaker insertion now can be outpatient. They will put the pacemaker in, and I don't know how many hours it is. I think they stay 6 hours. And if it's pacing appropriately, they can go home. It's really, really quite amazing. Here's another picture showing how this goes in through the vein, and these little electrodes on the inside of the ventricles, and then some of them will go in, or these are the atriums, and then that's atrial pacing, but you can also pace ventricularly. Next final thing is an ablation, and that's where there is hyperelectricity in the heart. So they go in and an ablation is like burning, and so they'll kind of snip the electricity off in certain portions of the heart if the heart is really overstimulated by electricity. There's a video here. Again, it's all just for your interest. None of this would be LPN skills, but certainly interesting. And then finally, cardiac defibrillation. So if somebody is in SVT, which is supraventricular tachycardia, we can defibrillate them two different ways. One with drugs, a drug called adenosine, and then with a defibrillator, either an AED or an external defibrillator, like you see on TV with codes, but it doesn't happen that way. Or some, again, pacemakers have a defibrillator in them. There is a live defibrillation video here that you can watch. You can also key in lots of different ones. Your job probably in an emergent situation in a code would be to do CPR and run. Go get this, go get that. So most of this last part of this video, remember as you're studying what the LPN role is. And you will probably not have patients that are this sick. Unless you have some really bizarre job in a cardiac unit, you would function probably more as a tech than anything else. So as you're studying, make sure that you don't go in depth on what happens in all of these procedures and what's wrong with the heart. You want to know the basics. And again, we're going to talk about the nursing process in class when we review this. So these are simply to get you prepared, help you focus your study, and I hope you found them helpful.